Chapter 17, Surgery. Now, the really good thing about this chapter is that you've had a lot of this before. You've had electrolytes, you've had pain, you've had IV fluids, you've had a lot of information. You already know a lot of information that we're going to be talking about. So this is a good recap for you to remember some things. So let's talk about the purposes of surgery. Now first I'm going to list them, then I'll go into talking about them. So there's diagnostic surgery, ablative surgery, palliative. Really important to know that what palliative surgery does is it relieves symptoms or improves function, but does not cure the patient. Reconstructive or restorative surgery, procurement for transplant, constructive surgery, and cosmetic surgery. So now let's talk about each of them. So diagnostic surgery actually is done to make an accurate diagnosis. It could be a biopsy of a skin lesion or a lump in breast tissue to diagnose what is the problem with the patient. Exploratory surgery is done to diagnose and determine the extent of a disease process. So this is usually done through the belly button. That's an exploratory laparotomy or laparoscopy. A scope is looking into the abdomen. They can do that through the belly button. A laparotomy, they would actually do an incision and open up the abdomen to find the cause of unexplained pain. But luckily now we have scopes that we can look in, and we can remove gallbladders, we can remove appendix, we can remove uteruses through an exploratory laparoscopy. Some exploratory surgery can be done using specialized scopes, like I was saying, inserted into the body through small incisions, about 3 incisions, 1 in the belly button, 2, 1 to blow up the abdomen with carbon dioxide so that they can see all of the organs and be able to remove what needs to be removed. Okay. Click. Oops. I think I skipped over something, didn't I? Sometimes I push this button just a little too fast. Ablative surgery is performed to remove diseased tissue. So ablation can be like really, really hot or microwave hot. So they burn away diseased tissue. My husband had a tumor in his kidney that they ablated. And what they did was they stuck in like a needle into that area. And it is a surgery. The patient is asleep. So they go into that tumor and they just blow it up, essentially. The microwave hot, they burn it out. So that's a really good thing because the patient doesn't really have anything removed, or they don't have to go through a heavy surgery because he was in and out with that surgery, whereas with some types of surgery, they're there for days, right? Now, palliative surgery is really important to remember because it relieves symptoms or improves function without correcting the basic problem. Now, your book uses the example of removing a malignant tumor obstructing the intestine, even if the cancer is widespread everywhere else. So the patient might have cancer, but part of that cancer that's malignant is obstructing another organ. So it could be into the lung. It could be, I had a friend who had breast surgery that had the cancer was going into the heart area. So they did a pericardial window where they opened up the pericardium and put a little extra space in there, like they call it a window, but it's not really glass or anything. But they just expanded the pericardium so the heart could move and function. So that's palliative surgery. Correcting, it improves function without correcting the basic problem. Important to remember that. Reconstructive or restorative surgery. So it restores function or structure to damaged or malfunctioning tissue. So breast reconstruction after mastectomy or total knee replacement are some examples that your book uses. Then there's cosmetic surgery performed to improve a person's appearance. Often the patient wants to change a physical feature, change the shape of their nose, remove wrinkles, flatten the abdomen, or change the size or shape of the breast. So here's some variables affecting surgical outcomes. So I'm going to list them and then I'll talk about each one. So the first one is age, nutritional status, fluid and electrolyte balance, the medical diagnosis going into surgery, what drugs are they on, and that's over-the-counter, prescribed, as well as illicit drugs, and what are their habits. So let's talk about age. So people older than age 70 who are frail or who have cardiovascular disease or diabetes or even COPD are at greater risk for surgical complications. And you can imagine, because if they have diabetes, that glucose level is under stress, and surgery, it makes the glucose go up. So it's harder to keep diabetes under control after surgery. And then cardiovascular disease, if their heart isn't functioning properly, it may put them at risk for complications. Now, another one would be lungs. So COPD may put the patient at risk for lung problems after surgery. They can't cough and deep breathe. Older adults in good health are likely to do just as well in surgery as younger people. Older adults respond differently to drugs because of age-related changes in liver and kidney function. Now, I know we've talked about that before. When there's changes in the liver and kidney that are filters, they're unable to filter as well as they used to when they were young. So it's going to affect drugs filtering through their liver and kidneys. Nutritional status. So if they're malnourished, they're going to be at risk for poor wound healing and infection. And if they're obese, so that two extremes, obese generally in surgery longer, and they're more likely to have post-op respiratory and wound complications. Well, why is that? Well, because they have a big belly, and that's going to impede on their lungs expanding. Because remember, they're sitting up and their belly is right there, and it's going to make them have difficulty taking a deep breath. The other thing is, if they've had an abdominal surgery, let's say, that every time they do cough, it feels like those stitches are pulling. So obesity can cause complications for their wounds opening up. Also, another thing is, it's harder for the obese person to move around in bed. So not only might they get skin breakdown, but also they just don't heal as well because the blood supply isn't as good in fat tissue as it is in regular tissue. They might need a trapeze above their bed so that they can help lift themselves up, so the bed can be changed so that they can change their own position. So it's hard to move an obese patient. It usually takes two people. Now, there are some beds that are specially made for obese patients, but usually they don't have a whole heck of a lot of room to move around, which can impede their healing. And I keep thinking, man, one more thing, it's hard for them to get up out of bed because it's more weight that they have to move. So they can be at risk for complications, many complications. Now, how about fluid balance? Well, if they have had some sort of vomiting or diarrhea prior to surgery, maybe that's why they're having surgery, they might not have adequate fluid balance. So they need that to maintain their blood volume and urine output. So they're already working on fluid imbalance or hypovolemia. If they have too much body fluid, that can overload the heart, and that can aggravate the stress of surgery. Sudden changes in fluid volume are especially dangerous for the older patient. So remember, the older patient is already on the verge of dehydration. So just a little loss of fluids or blood, they're hypovolemic. Now, there will be IV fluids going during surgery, but they're at risk for having a fluid volume deficit. And they're very sensitive to those changes. Even when they get up out of bed, remember that change of position can put them at risk for hypotension, dizziness. They could fall, and you don't want to fall after surgery. Electrolyte imbalances may predispose patients to dangerous cardiac dysrhythmias. So we just talked about electrolytes. Do you remember the electrolyte that could lead to a dangerous cardiac dysrhythmia? Well, it's potassium. So potassium is an intracellular electrolyte, and it's in the cell. And it can lead to cardiac dysrhythmias. So if they have a loss of fluids, they might lose electrolytes, and then they're going to be hypokalemic. So then, as a nurse, you have to watch the labs so that you see how their electrolytes are. The medical diagnosis. So if they're at risk for bleeding disorders, they're at risk for excessive bleeding and must be closely monitored. So if they have a baseline bleeding disorder, and there are some, like, I can't think of one right off the bat here, but if they have a bleeding disorder, they're at risk for excessive bleeding. Maybe they're on blood thinners, or they were on blood thinners. Heart disease. So cardiac complications related to anesthesia, the stress of surgery, can be a problem. If they have COPD, pulmonary complications due to anesthesia or hypoventilation. Liver disease, impaired wound healing, may experience drug toxicity from the inability to metabolize drugs effectively. And if they have diabetes, they heal more slowly and they're at greater risk for infection with all that glucose going through their veins. Plus, they don't heal as well, do they? Diabetes patients heal slowly. So let's talk about drugs. Many drugs have the potential to interact with anesthetic agents. Serious adverse effects may result. The effects of surgery or additional drugs may require dosage adjustments in drugs the patient had been taking routinely. Also, over-the-counter medications such as aspirin can affect recovery and must be documented. Now, why aspirin? It's just over the counter. Well, aspirin at 81 milligrams is a blood thinner. So if they were on a blood thinner, that could be a problem. Also, some herbal drugs, and it's in your book. There's a pharmacologic capsule even on page 2 68. So it's vital to document all drugs, prescription and other drugs that the patient has been taking pre-op. So the capsule says that drugs that should be held or modified before surgery include anticoagulants, non-steroidal anti-inflammatories, NSAIDs. They can impede the healing process. Also aspirin, the blood thinner, and some herbal products like ginger, ginkgo, and ginseng. So when we take the history of our patients, that's one of the things we always want to document is drugs, not only the drugs that the doctor prescribes, but also the over-the-counter drugs that they're taking. And even teas. If a tea has an herb in it, we need to know about that. And they're not going to think to offer that information up because they really don't think of it as a drug. So we always have to ask when we're taking a history. So in your book, it talked about habits. So habits that alert the patient to the possibility of specific peri-op complications are smoking and the use of recreational drugs, alcohol. How much alcohol do they drink? If they're an alcoholic and they go in for surgery, they could suffer withdrawal. And the same with cigarettes too, because if you see your patient getting tachycardic for no reason, there's never not a reason why they get tachycardic. It could be stress. It could be drug withdrawal. It could be caffeine withdrawal. It could be alcohol withdrawal. It could just be maybe they're bleeding. I mean, it could be so many reasons. So whenever you see something abnormal, take note and try to find out why that is. We have to play detective sometimes. All right. So let's go on to pre-op assessment. So you want to get a good health history, do a review of systems, functional assessment, and physical exam. So I'm going to talk about each one of these things, but I want to say throughout the physical exam, be alert to the patient's emotional state, ability to communicate, and ability to understand directions. So maybe they don't speak English. So maybe you need another family member there, or you're going to need an interpreter. Okay. So taking a good health history, identifying data. So you want to record identifying data, the patient's age specifically, history of their present illness. Why are they here? Describe the problem that's being treated surgically. Be sure they know why they're there. Be sure you get their allergies, any medications that they take, and their medical history. Oops, forgot the why there. So you want their medical history because you want to know if they have heart disease, if they have renal problems, if they have liver problems, or we want to know if they've ever had surgery before and have they had problems during that surgery. And that goes into the medical history as well. So include acute and chronic conditions, hospitalizations. What have they been hospitalized for in the past? Is it related to this hospitalization? What surgeries have they had? And did they have problems during those surgeries? We always want to be on the lookout for potential problems. Allergies. So we want to know their allergies, not just to drugs, but foods as well. Tape, gloves, latex, and their allergies. drug history, record all chronic health problems. So diabetes, that will help us. Diabetes, said that, heart failure, heart problems, even valve issues. Pulmonary disease, do they have COPD? Kidney problems, because these can affect how they get rid of anesthesia or medications. Another thing is, do they have hepatitis C? Have they ever had a history of hep C? Because that makes a difference to the worker, doesn't it? It also might make a difference, did they take medication for hep C? Are they immunocompromised from that? And we want to document, of course, allergies, the food, drug, tape, chemicals. Now, I realize I may be repeating myself, but that's okay, right? Because it takes 3 to 5 times to remember something. So if I mention it 3 times, maybe you'll remember, right? All right, let's go on. So a review of systems. So we want to collect all the data about each body system, noting any abnormalities. We want to record any disabilities or limitations. Document problems that might be significant during the surgical experience, such as vision. Like I wear contacts, so I'd need to remove my contacts before surgery, and then I have my glasses. But be sure I do have my glasses or I won't see anything. And then hearing loss that goes along with hearing aids. A lot of times they tell you to leave those things at home. Well, that's fine, but be sure you bring them back after surgery so you can hear what's going on. Partial paralysis or joint stiffness, and maybe that's why you're here, because of joint stiffness. You're going to have a knee or hip replacement. Weakness or any cognitive impairment. Can they understand the directions that you're going to be giving them? Functional assessment. So functional assessment is always important. Their usual activity, how they function, their occupation. It could lead you to, if you found out they were a janitor and inhaled chemicals that affect their lungs, that could tell you they might have issue after surgery with their lungs. What roles and responsibilities do they have? Are they the head of the household? That might affect the stress level. How they're so stressed because they know they need to get back to work, or they know they need to get back to help with take care of the family. Determine the usual diet and fluid intake, and tobacco and alcohol. Note exercise and rest patterns. So a person who exercises 3 times, 5 times a week is probably in pretty good shape, and they'll bounce back a lot faster. Are there rest patterns? Do they need a nap? Ask about sources of stress and support. And what is their usual way of coping? So this is really important because a lot of times our patients will tell us something, and the way we want to respond back is, how do you usually deal with that? What is your usual way of coping? And they may not connect this problem that they're having now with problems in the past, but the way they coped may help them both ways. So here I'm going to list some interventions, and then I'll talk about them. So anxiety. What I want to say here, yeah, I know I said I'd say more later, but so I repeat myself. If the patient's anxious prior to surgery, call the doctor. They may need medicine for that anxiety. And this is before the surgery. So they're just anxious. The surgery may be postponed if the vital signs are above normal. So you have to notify the doctor. If those vital signs are really, really high, maybe the doctor will order medication prior to surgery or might postpone the surgery until their vital signs get within normal range. Inadequate knowledge. Do they really know what's happening? Do they know why they're here? Do they know what's going to be done? And then we're going to prepare them for surgery with an informed consent, prepare their digestive tract, food and fluid restriction, skin preparation. We're going to talk about dress and grooming, if they need a prosthesis, talk about their circulation, pre-op medications, and pre-op checklist. So we're going to go through each one of these. So pre-op teaching. Patient teaching in physician's office, clinic, and during pre-admission workup or after hospital admission. So pre-op teaching is really important because if they know what to expect, their stress level will lower. And also, if we teach them how to use an incentive spirometer pre-op, the right way to use it, then post-op, it'll be a lot easier for them because you've already told them once. Remember, patients too benefit from telling them more times than one. So we want to give verbal instructions that are going to be implemented, supplemented with written material. So maybe we have pamphlets to hand them out and their family members. Always remember the family. Teaching methods. So direct teaching by the nurse is used most often. We are teachers. Some hospitals have classes for pre-op patients. And that's if you've scheduled it ahead of time and you have plenty of warning, of course. There's books, pamphlets, audio tapes, and videotapes. Preparation for surgery. So I want to go back for a minute and talk about that anxiety. The interventions. So most patients are anxious and fearful. So remember, if the patient is excessively nervous or fearful about the surgery, report that to the doctor. So now we've got vital signs we're going to watch for. If those are abnormally high, if their anxiety level is high, we want to let the doctor know. Maybe we can give them medication for that. Because fear is associated with surgical complications. Stress and fear. In some cases, the surgery is postponed until anxiety is reduced. So on page 271, it does talk about pre-op teaching. There's a pretty long, it's one half of the page, literally. So it talks about all the pre-op teaching that can be done. When I used to teach cardiac, not teach, but I was working on the cardiac surgery floor, I would actually take the pre-op patients to the ICU so that they could see you're going to have tubes. You're going to have a tube down your throat. You're going to have a tube in your chest. You're going to have an incision down the middle of your chest. Now, you're thinking, well, that might scare them. Well, not really, because knowledge is power. So they see that that person's doing well, even though they have all those tubes. So it really does help. It improves their recovery. So informed consent, I want to talk about that protects the patient from unwanted procedures. So that's the purpose of the informed consent. And I'm on page 272 in case you wondered, where is she? So the purpose of written consent is to protect the patient from unwanted procedures. It also protects the healthcare facility and caregivers. Yeah, we did tell you, right? We had it written on this piece of paper. Explaining the procedure and risks to the patient is the physician's responsibility. but the nurse may obtain and witness the patient's signature on the form. If the patient has any questions whatsoever that the doctor didn't order, you need to let the doctor know, and he needs to come and talk about those concerns before the patient signs the consent. So if they have any doubt, because sometimes doctors, when they're explaining what they're going to do, they use big words, exploratory. Well, I don't know what that is. I don't know what that means. Well, if they ask you, what exactly does that mean? If you tell them something wrong, or if you tell them what you think, or what's the usual, maybe that's not what the doctor meant. So if they have any questions, say, well, what did the doctor tell you about that? Find out what the doctor said to them, or what they thought the doctor said. And if that's not really what's going to happen, then you need to call the doctor before the consent is signed. And one thing I want to add here is that student nurses should not serve as a witness. This is a document, legal document, so you don't want to have your name on there at this point, being a student. All right, so more preparation, preparing the GI tract. So we want some surgeries, bowel prep. If they're doing colon surgeries, that bowel needs to be cleaned out. Because remember, the GI tract is dirty. And if any stool, let's say they have to open up the colon and stool comes out into the abdomen, that's a source of infection. The abdomen will need to be rinsed out, maybe with antibiotics or normal saline, if it's not clear. So the doctors like to prepare the GI tract and just clean it all out so it's nice and clean. Food and fluid restrictions. So on table 17.2, it does talk about pre-op fasting recommendations by the American Society of Anesthesiologists. So notice that clear liquids are water, clear tea, black coffee, carbonated beverages, fruit juice without pulp. Clear liquids. All right, then there's skin preparation. So when they're going to make an incision, microorganisms can enter the wound. So by cleaning the skin, and that may be a betadine shower the night before surgery, and then getting into a clean bed. It's cleaning the skin of the bacteria. Also, they recommend that the patient maybe clean their own skin, shaving the area, removing the hair, so that that can be done at home. So the shower with the antiseptic soap, like I said, betadine, but it could be anything that the doctor ordered that cleans the skin. As I said, the hair needs to be removed, clipping or electrical. They don't like to use a razor anymore because of the bleeding, but if you have an electric shaver, that can remove some of the hair. All right. Oh boy, one time, notice in the book here it says, if shaving is done, it's best delayed until shortly before surgery to allow less time for organisms to multiply. But also, the thing is that I had a patient, and this was before heart surgery too. So he had a long beard. It wasn't for religious reasons. It was just because he had a beard. But I had to cut that beard with scissors, and then I had to shave that guy and shave his skin, because of course his body was hairy also. And now the reason he couldn't do this before is because this was an emergency. So, but it took me 2 hours to shave and clean up this guy. So that's another reason why they like it taken care of before you come in. Dressing and grooming. So on the morning of surgery, be sure that you provide a clean gown and remove undergarments. All jewelry should be taken, body piercings, a ring. If a ring can't be removed, or if the patient doesn't want to remove a ring, you can put tape around that. Remove nail polish, because we want to assess nail beds. Also, O2 saturation that goes on the finger, it doesn't work well when there's a lot of nail polish on there. So the pulse oximeter doesn't work as well. Acrylic nails, that needs to be consulted with the anesthesiologist, because sometimes they don't want you to have acrylic nails, because for the same reason, it prevents the capillary beds being checked. The pulse oximeter may not work as well. Now, some people like to go to the hospital all made up, right? Looking good before surgery. But usually makeup, including mascara, should be removed. Oils or creams should not be left on the face or body, because they might be flammable with oxygen in the ER. Now remember, they need also to have a wristband, and it should indicate allergies and any other precautions of the patient may need, and an ID band also, allergy band. So another thing we're going to talk about is circulation, because it's important to reduce the risk of blood clots. We're going to prepare them for surgery. We might put on stockings, or the ones where the air blows through, compression stockings, to reduce the risk of blood clots. And then there's a list of pre-op meds on table 17.3, and that's on page 274. If you want to turn and just look at the meds there. I'll just talk a little bit about them. We don't really go through the meds here, but I know that it helps you in pharm, so let's just talk about them for a minute. So some pre-op meds would be Thorazine, which is an anticholinergic, so it might dry the mucous membranes. It also has a sedative, an antiemetic effect. It can also cause hypotension and dizziness, though. So you notice the dry mouth, blurred vision. So be sure, if you give any medications, keep the patient in bed. And if they need to get up, be sure that you're with them because of the side effects. Same with Valium. It's a central nervous system depressant. Diazepam. Any PAMs are usually sedative type medications, depressants. It can be given IM, IV. Can cause respiratory depression, dysrhythmias, drowsiness. Then we've got Vistaril, Atarax. Those are CNS depressants, anticholinergics again. They're going to dry the mouth. And if you're following with me, you'll see the medication, the use, and then the side effect, and then your nursing interventions. Phenergan's a good one. It's a good one because it helps relax the patient, sedates the patient. It's an antihistamine, helps with allergies. Anticholinergic will dry up dry membranes. Antiemetic, so they don't feel nauseous. It continues over on page 275 with some other. Demerol is an opioid analgesic. It's used for sedation. It can cause lightheadedness, respiratory depression if you give them too much. Morphine is another analgesic. And then some other sedatives and hypnotics, Nembutal. We don't use that too much anymore. Seconal, we don't use that much anymore either. Now there's so many new drugs that are used to replace the old drugs. And a lot of them have less side effects. And that's a good thing. Okay. So who's on the surgical team? Let me just look here before I turn. So on page 275, there's a pharmacologic capsule. Because pre-op meds have a sedative effect, the surgical consent form must be signed before any meds are given. That's really important. And the medications are given, raise the side rails up. So after you've given any kind of sedation type of medicines, be sure their side rails are up, their call lights within reach. We want them to be able to call if they need something, and we don't want them to fall out of bed. All right, so who's on the surgical team? Well, the surgical team consists of the surgeon, and he needs an assistant. There's usually a registered nurse who circulates. So she or he are not sterile. They circulate and they get things that are needed. They may take specimens to the lab or to have the biopsies looked at. They may put the Foley catheter in. Then there's a registered nurse that's an assistant that helps with the doctor, so usually sterile. There can be a registered nurse, LVN, or surgical tech, also scrubbing in, anesthesiologist, and other specialized technical personnel. Now remember, the anesthesiologist or the nurse anesthetist, those are people that specifically have had training on anesthesia. The surgeon performs the surgery. I want to talk about that circulating nurse, though. I'll tell you a funny story. So I had surgery one time, and they roll me into the OR, right? Bright lights, everything's bright. It's cold in there, and you're scared anyway. You're nervous. So the circulating nurse came up to me and said, so I'm so-and-so, and I'm going to be circulating around and getting things that the doctor needs if we run out of anything. I said, well, where's the music? Because every OR has music, because doctors like to operate to music. And as a patient, music calmed me down. So I said, where's the music? And he said, oh, the doctor doesn't like music in his OR. And I said, well, the patient likes music. And so he goes, okay, I'm going to turn it on, but believe you me, when the doctor walks in, he is not going to like it. And sure enough, he was kind of this big guy, and he comes in, he goes, why is that music playing? And the nurse goes, she wanted it, the patient wanted it. He goes, okay, but as soon as this song is over, I want it turned off. And that was pretty funny, but it helped calm me down. So you can remember that. Circulating nurse, so they maintain patient safety, they watch the room and equipment, set up everything, monitor, maintain aseptic technique, they keep an eye on everybody, assist in positioning, monitoring the patient. And another really important job is documenting. Now remember, I know one of the the things that you guys have to present, your presentations later, one of them is an object is left in the patient. Well, we don't want that to happen, so that's why we count, we document after surgery before what's being used, and then what came out of the patient. Be sure the count is correct. That's very important. So documentation is important. Anesthesia. So there's different types of anesthesia. So we need to know about some of these. So local and regional anesthesia, it blocks the conduction of nerve impulses. And it may wear off, and the patient may experience numbness, but the motor will return before the sensory. So that's kind of interesting, isn't it? That motor sensation returns before sensory. And that's why a patient can move their arm and not feel that they've moved it, or they can't feel the side rail. They can move, but they can't feel it. Now with spinal anesthesia, remember the patient can get a headache from spinal anesthesia. Then there's general anesthesia. There's inhalation agents. Pentane is an inhalation agent. Those are used for most procedures using inhalation agents. The patient is first induced with a short-acting IV agent that causes loss of consciousness, and then an endotracheal tube. Now I'm on page 279 so that you're with me. After this inhalation agent, the patient will have an endotracheal tube put down into the trachea to permit administration of anesthesia and also to control ventilation. Now, when the patient wakes up, if they did have an ET tube, an endotracheal tube, they might have a sore throat, or they might feel hoarse. And they'll go, why, if you operate on my leg, why is my throat sore? Well, maybe they had inhalation anesthesia. There can be IV agents like pentothal. Also other agents like muscle relaxers, benzodiazepines, supplemental opioids. It's really popular right now too to give IV Tylenol because that potentiates opioids. So it will potentiate any kind of pain medication. It will help that along, and it's not harmful. Now, there's a big complication with anesthesia that you need to know about. It's in your book on page 279. It talks about malignant hyperthermia. It's life-threatening. What's interesting about that, and when you take a history, you need to find out about have they ever had surgery for, and did they have any complications? Well, malignant hypothermia is a life-threatening complication, and it's inherited. So if they had it before or if their family member had it, that's important information to know. It's also important for you to know that it can be inherited. So susceptibility to this response is inherited. So it's a malignant hypothermia, life-threatening complication, occurs in response to certain drugs. What happens is the body temperature and metabolic rate, tachycardia, hypotension, cyanosis, and muscle rigidity. All very difficult. So you'll need oxygen, maybe some Lasix, some diuretic. You might even need a crash cart around. So moderate sedation or conscious sedation. This is the type of sedation they'll give like for a colonoscopy, say, so the patient can be easily arousable, but they go right back to sleep. So like for a colonoscopy, I'm just going to use this for an example because I know about this one. So they're given this medication. If you call their name, Debbie, I might open my eyes and then I go right back to sleep and I won't remember a thing. So it's good if they need to be positioned, they can help, but they will never remember anything. So easily arousable. It's the use of IV drugs to reduce pain or awareness without the loss of reflexes. So that's important for you guys to know. But then when they start to wake up, you need to watch for their level of consciousness because that's been affected. And this is on page 279 under moderate sedation. It talks about during the procedure, the patient's vital signs, oxygen saturation, their airway, and level of consciousness, and EKGs may be part of the assessment. Now, it's really cool. They have oxygen that goes in the nose, nasal cannula, but it also measures their CO2. So not only can you do an O2 saturation, but you could also see if they're retaining CO2. So that's really good for ventilation purposes and for patients who have lung problems. Okay. Let's try a question. So what kind of surgery is a more extensive procedure than a biopsy? It usually requires opening a body cavity to diagnose and find out the extent of a disease process. I'll give you a minute. It's to diagnose and find out the extent of a disease. So the answer is C, exploratory. So exploratory surgery is a more extensive procedure than a biopsy. It requires opening a body cavity to diagnose and find out the extent of a disease process. A common example is exploratory laparotomy, in which the abdomen is opened to find the cause of unexplained pain. Question number 2. So which of the following statements is true related to surgery? So I'll give you a minute. So the right answer is D. This is true statement. It's the physician's responsibility to explain the procedure and risks to the patient. The nurse can obtain and witness the signature on the form if your agency policy allows. Sometimes some facilities want the patient to sign the consent, maybe in the doctor's office. So if the patient has questions or seems to be in doubt, you need to call the physician so he can clear it up. Okay. So let's talk about some surgical complications. So this is listed on table 17.4, if you want to turn to that, page 281. So some things that pop out to me here. Shock is an important one to know. Treatment, it's related to deficient fluid volume, so they might lose blood, which is blood volume, right? So they might require fluid or blood replacements. They might even need vasopressors, so drugs to raise their blood pressure up if they go into shock. Hypoxia, related to ineffective airway clearance, so they need to cough. They have to cough and deep breathe. Remember, we have to have our patients cough and deep breathe. We're going to teach them before surgery how to use that incentive spirometer to take a deep breath. And we also, after surgery, want to encourage deep breathing and coughing. And we want to watch their O2 saturation. So O2 saturation, if it's below 90%, that's not good. Not good. They need to cough, deep breathe, sit up, and see if you can raise up that O2 saturation to above 92%. That's more acceptable. It's acceptable, not optimum, right? Maybe they just have a mucus plug that they need to cough out, but they're afraid to cough because they've just had surgery. They have an incision, so they need to splint that incision so they can do a nice cough. So I usually say just grab onto that pillow and give me a good cough. Make them just cough up. All right. Wound complications related to impaired wound healing. We're going to talk about dehiscence and evisceration. Also, infection could be a problem. Inadequate oxygenation, so the pneumonia and atelectasis. We don't want atelectasis. What does that mean exactly? So the bases of the lungs are collapsing. So the alveoli are not expanded. So that's the purpose of taking a deep breath to expand that alveoli. Because once they get atelectasis at the bases, they're going to get pneumonia next. So those could be complications. The wound complications, GI disturbances, urinary retention and renal failure, and thrombophlebitis. Another thing I want to talk about, well, yeah, I'll talk about it here while we've got this surgical complication table. So after surgery, urine retention is a problem because some guys can't pee laying down. And what if it's right after surgery and they need to pee, right? They need to urinate within 8 hours. And so you might have to sit them on the side of bed in a natural position so that they can urinate. Also, it's hard to urinate on a bedpan, isn't it? You want to be sure to provide privacy for your patients. Offer warm bedpans. Those bedpans are pretty cold. If they have to sit on the side of the bed, be sure that you are there with them so that they don't fall. And another thing I want to add here that's on this surgical complications table is if they're NPO, nothing by mouth, they can't have anything until bowel sounds return. So that's why we're always going to listen to bowel sounds. I know they used to say, have you passed gas? But if you hear a gurgle, it means peristalsis is beginning. So they may be able to start fluids. So nothing by mouth until bowel sounds return. So those are some really important things on that table. Now we're going to talk about each thing. So what is shock? Shock is the effect of anesthesia or loss of blood or fluids, any fluids, right? Sometimes we have drains that are draining out excess fluids from the wound. So we always want to measure output and be sure what's going in is coming out. Hypoxia can be from inadequate oxygenation of body tissues. So we want to have them take deep breaths, and when we medicate them, that might depress their respirations. So you have to keep an eye on their respiratory rate. That's also important. And anesthesia can depress the cough and swallowing reflexes. And then sometimes vomit and saliva can enter the airway, and then that can cause a pneumonia that way. Okay. So injury because of decreased level of consciousness associated with general anesthesia or other sedatives. So they're at risk for injury because of that decreased level of consciousness. Let's talk about the pneumonia and atelectasis again. So that can be drug effects and immobility, just placing the patient at risk. Again, with chest or abdominal surgery, they don't want to take that deep breath because it pulls on their sutures and it's painful. So pain medicine helps, but then they get sleepy and then you have to wake them up and then the pain starts again. It's kind of tough after surgery. The first 48 hours is pretty tough. Immobility limits lung expansion and allows fluids to pool in the lungs. Fluid provides a medium for infectious organisms to grow. An infection of the lungs associated with immobility is called hypostatic pneumonia, and that is on page 282 under pneumonia and atelectasis. One of the problems. Complication. Wound complications. So dehiscence and evisceration. So let's talk about that. There's a really good picture on page 282. Well, when I say good picture, it's not so pretty, but it tells you what it means. So notice so this is figure 17.8. Dehiscence is the first picture, so that's where the sutures pop open and the wound opens. That's dehiscence. It's a reopening of the surgical wound. Now, evisceration, the body organs protrude through the opening. So that picture you're seeing there on B looks kind of funny, but that's like intestines sticking out, protruding, and the little globs of fat. It's a gross picture. I can't even look at it. Ugh, yuck. So remember, dehiscence is opening. Evisceration, the organs actually come out. What do we do when that happens? What do we do? Well, we immediately cover it with a 4x4 if you have that, and some saline. Because if an organ pops out through the wound, that's used to being inside the body, covered, moist. So we need to keep it moist, or it's going to dry out and die. So cover it up to prevent infection, and also some saline, if you have that, is good. They're at risk of dehiscence increased by wound infection, malnutrition, maybe their skin, they weren't in such good health when they had surgery, obesity, dehydration, and extensive abdominal wounds or injuries, and sometimes dirty car accidents. Your wounds are not always clean. The doctors try to clean everything out with saline and antibiotics, but sometimes things get missed. Also, stab wounds or gunshot wounds can cause extensive injury internally. Infection, greatest in traumatic injuries because of the dirt and a knife, dirty knife that was used. Wounds not treated promptly and wounds that were infected before surgery can be at risk for infection. So if they were dirty before surgery, they're at risk for infection after, even though the doctor may try to clean them out the best he can. Sometimes extra tissue even needs to be removed to get that disease or dirtiness out of the area, especially with infection. So if you have, let's say, a ruptured appendix, so that's internal. The doctor has to go in, remove that ruptured appendix, and then, the appendix is attached to the ileum and the colon. So what if some stool came out? You weren't prepped for that. That was an emergency. So the doctor has to clean up, and sometimes things are not seen by the eye. So you're at risk for infection. So some GI disturbances, nausea and vomiting, that can be due to medication or anesthesia. Impaired peristalsis. So when you get anesthesia, usually your peristalsis stops. So everything's kind of at a standstill. And that can lead to constipation, as well as you're on pain medication, so that leads to constipation. So you're really at risk for that. Peristalsis is can cause problems until that starts back up again. Sometimes that takes days. The causes would be anesthesia, pain, opioids that normally cause constipation, decreased peristalsis, and resuming oral intake too soon. So if you start fluids too soon, or maybe you think it's the right time, but your body says no, so you have nausea and vomiting, and then you're losing electrolytes and fluids. So that time right after surgery is very important to be sure that you keep track of I&O and that you take care of any problems that the patient presents with. Okay, just keeping track in the book and the slides so that we can follow along. So urinary retention and renal failure. So the kidneys produce urine, but the patient's unable to empty the bladder. So that's urinary retention. And that can be caused by anesthesia or opioids or even trauma to the urinary tract or even anxiety. Sometimes people don't like to urinate in front of others. So they're anxious, not only about the surgery, but anxious about peeing in front of somebody. Volume may be decreased due to dehydration or blood loss. So also kidney failure. The kidneys are unable to produce enough urine to remove waste from the body, and urine production can fall dangerously low. So after surgery, it's really important to follow the blood, the labs. WBC indicates infection. Hemoglobin hematocrit may indicate blood loss. BUN and creatinine, kidneys. So you're going to begin to learn these labs that affect certain organs. So be on the lookout. Okay. Other complications, thrombophlebitis. Blood clot in the leg after surgery. Occurs most often in the legs, so that's why we do the Homans when we do our head-to-toe assessment. We're checking for a blood clot. A lot of times after surgery, they have been laying for a period of time inactive, and remember that blood could pool and form a clot. We would put on the TED hose or the compression devices used as a prevention of a blood clot. Clots that cling to the walls are called thrombi, and they can break loose, pass through the heart, and lodge in the pulmonary circulation, or go to the brain and cause a stroke. Now let me tell you a story here. So my husband had surgery, and he was put in Trendelenburg position. Now, Trendelenburg is where your head is lower than your feet. He was put in that position because he had a robotic procedure. Well, now, think about it. The blood came out of his legs, right? Because they're up higher than the head. And he had some complications during surgery, some blood loss. So he really had a loss of blood flow through his legs. Well, guess what? The next day he had pain in his calf, and he told the nurse, I have calf pain. And she checked it. She did a Homans, negative. Checked it, not hot. Checked it, wasn't swollen. So they said, well, let's just go for a walk. Let's just walk around. So he did, and he walked around, and he walked around, and he walked around, was doing really good, went home. And lo and behold, he had a blood clot the whole time. And he got a blood clot, and one morning when he got up to go to the bathroom, and he threw a blood clot to his lung and got a pulmonary emboli, not even knowing he had a blood clot in his leg. So sometimes it doesn't always present as a Homan sign, or as a swelling, or as a redness, or heat, where your calf is heat. But when your patient complains of calf pain, maybe an ultrasound is in order, because that could have been found out. Then let me tell you another story. Another story. My daughter, 28 years old, just doing at home, right, because of COVID. Not surgery related at all, but she wasn't moving around a lot because of COVID, not being able to leave the house, having to do a lot of work in a sitting position, crossing her legs probably on birth control pills. And she started complaining of calf pain. And that's weird, to have calf pain, you're not doing anything. Didn't have surgery. And then pretty soon her foot started swelling. So she called me up and she said, is this anything? And I'm like, oh yeah, maybe you had a blood clot. You need to go to have that checked out. So she goes to the doctor, and she had a huge blood clot in her leg, like almost to her knee. That's how big the clot was. Now, if that would have broken off and gone to her lungs, she could have had a pulmonary emboli, and a lot of people die from that. And she would have been a very young person to die of a pulmonary emboli. So blood clots get up and move around. That's why we don't stay still in one position for very long, whether we're in the hospital or not. So that's just a little side story. Just be sure that you move around. Don't be sedentary. We know sedentary can lead to a lot of diseases also. All right, let's move on. You're like, Debbie, stop telling stories. All right, so the immediate post-op nursing care in the PACU. So assess patient status, especially their level of consciousness and their vital signs. Really important. Inspect their wound or dressing. So if you notice any drainage, you want to circle that with a marker so that you know, are they bleeding more? Or is it just a drain? Is it just drainage from the wound, or is it bleeding? Sometimes you can't tell because you're not the first one to change a dressing, and you do not change a dressing. That first dressing after surgery, the doctor does that because he wants to inspect the wound. So check and set up equipment like suction devices if that's needed, an NG tube, any oxygen, any urinary drainage bags or IV lines. Those should be all ready for the patient when they come right out of the OR. So in your book, it talks about some interventions. So you want to do a focused assessment as soon as the patient comes back. And again, I'm going to reiterate, level of consciousness. Are they arousable? Be sure that you can wake them up. If they go back to sleep, that's fine. But if they wake up, because they'll slowly start waking up more and more as the anesthesia wears off, check their vital signs. Are they stable? Because if the blood pressure starts to drop and the heart rate goes up, that could mean a sign of impending shock or they're bleeding somewhere. I'm going to talk about that again in a second, just to reiterate. So you've got the suction ready, the oxygen ready, and the IV lines all set up. And so you want to check and be sure everything's going to where it should go, right? So post-op intervention. So here's our decreased cardiac output. So be alert for the possibility of shock. Page 283. Shock. You got to know the signs and symptoms of shock. Rapid, thready pulse. Hypotension. Blood pressure drops, heart rate goes up, trying to compensate for that low blood volume because maybe they're bleeding, right? Also, restlessness is a sign of shock. So you've got, and in your book it says, signs and symptoms of impending shock include a rapid, thready pulse, restlessness, decreased blood pressure, and decreased urine output. Because if you're low on blood volume, whether it be blood or fluids, the kidneys shunt the volume to other areas, and then they're not getting enough blood flow. The kidneys aren't, so the urine output's going to drop. So measures to reduce the risk of shock include prompt recognition, treatment of bleeding, replacement of lost fluids, so I&O is very important, intake, output. Remember, even drainage from a wound is output. Frequently inspect wound dressings and drains for color and amount of drainage. The amount of bleeding expected varies with different surgical procedures. So be sure that you know what the signs of shock are and how to treat it. And be sure you check the IV site, check patency, be sure they're getting the fluids they're supposed to be getting into their blood vessel, into their veins, because maybe it's infiltrated. Remember we talked about infiltration of IV sites, so you want the blood, you're pouring fluids in, be sure it's going to the right place. And be sure you check the dressing for any signs of bleeding. All right, inadequate oxygenation. That's a big deal. I know we've talked about it before surgery. We're talking about it during surgery. Now we're going to talk about it after surgery. So monitor their respiratory status. Assess their depth and rate and effort of their breathing. How is their effort? Are they straining? Is it shallow respirations? Is it deep respirations? What's the rate? Are there tachypnic, a fast respiratory rate, or is it really slow? You want to listen to their breath sounds. Do they sound regular, normal? So you want to go from side to side on their lungs, right side, left side. Compare each side, and you want to hear breath sounds all the way to the bases. You also want to check their O2 saturation, very important. Be sure that they're taking deep enough breaths so that their O2 saturation is greater than 92%. Note the color of the patient. Are they getting cyanosis around the lips? Bad sign. It's a late sign of hypoxia. Check their nail beds. You may use airway inserted until patient's awake. So there is a little airway, not a big one, but it's just a little one that kind of keeps their tongue from falling back while they're asleep. And that's just until they wake up. Position an unconscious patient on their side to reduce risk of aspiration. And it does say that on page 284 under inadequate oxygenation. So what are some interventions for pain? So we want to medicate the patient in the early post-op phase, and we want to always follow the doctor's order. And be sure you know when was the last dose given, so you know when you can give the next dose of medication. And we learned in the last chapter that it's better to kind of keep a regular pain control level. Give them pain medication when it's due, of course, not too soon. But we want to keep them medicated so they're out of pain, so they can do deep breath, so they can get on this side of the bed and maybe dangle or be able to urinate. So physician's order and nurse's judgment, how we give medication for pain. Of course, you want to be sure that the oxygenation is good. Check for confusion. You want to explain what to do. Simply be calming and reassuring to your patient. Potential for injury. So if they're drowsy because of pre-op and intraoperative sedatives, they're at risk for injury. They can get up out of bed. So you want to have the side rails up and call light within reach. After spinal anesthesia, the patient regains the ability to move the legs before sensation returns. So you want to chart that the patient regains both movement and sensation. Assess the bladder for distension. So just, you can palpate just above the bladder. And the patient's family, be sure that many surgeons will speak to the family after surgery, tell them how it went. So they'll be waiting in the waiting room, and then after the surgeon's spoken to them, they'll be waiting to come visit the patient. So if they're in recovery or in the PACU, when the patient's stable and when you've got everything that you need done, you can have the family come in. So discharging from the PACU. Vital signs are stable. Respiratory and circulatory functions are adequate. Patient has minimal pain. The patient's awake or can be awakened easily. Complications are absent or under control. So we don't want to take them out to the floor until everything's good, right? Vital signs stable, respiratory rate good, oxygenation good, pain minimal, patient's awake, maybe even asking for a sip of fluids or ice chips if the doctor has that ordered. Gag reflex is present. So the presence of a gag reflex is important before they go out to the floor. They have to be able to handle their secretions and be able to swallow. And most patients remain in the PACU for 1 to 2 hours, but it depends how they're doing. Are they ready to go out to the floor? So just looking here at your book on page 285, it talks about the criteria for letting the patient go out. Their O2 sat needs to be greater than 92% on room air. It actually gives a score if they're ready to go out. Their dressing's dry and intact, they're free of pain, they can stand up, or at least they're not dizzy, or maybe they're able to sip fluids or ice chips, and have they voided. Maybe they're not quite ready to void yet, but they're still comfortable. And be sure you keep the side rails up and the call light within reach. Very important, always. Okay. Post-op assessment. So this is box 17.4. There is a great nursing care plan, by the way, on page 286. It talks about the health history of a patient, 37-year-old, having abdominal hysterectomy. And I want you to notice on that page there under the care plan, it talks about potential for infection. So you want to do aseptic technique for wound care and monitor their I&O and the drainage on their dressing. Also, inadequate oxygenation related to stasis of pulmonary secretion. So we want to have our patient cough and deep breathe and turn and do the incentive spirometer every 2 hours. And that incentive spirometer, the purpose of an incentive spirometer is to take a deep breath and hold it so that you keep those alveoli expanded, so that good air exchange in the lungs. All right, so we were talking about the physical exam in the post-op assessment. Be sure you check their neurological status, their vital signs, their skin, warm, dry, cool, pale, their thorax, their chest. Is it expanding equally? How's their heart rhythm? And is it regular? Is their abdomen soft? They have bowel sounds. Their extremities, do they have pulses? So we want to check pain and be sure that you verify the last dose of pain medication. There's a lot of times there's a problem when a patient's transferred from the PACU. So be sure you check the MAR when the patient had their last pain medicine. And then if they've been switched from IV to oral or IM, how is it given? Be sure you check that. And how is the patient's response to any analgesia should be addressed within 30 to 60 minutes. So when you give them medication, did it work? And usually there's a place to document that. If it was a 7 to start out with, then in 30 minutes it's down to a 4. So on a scale of 1 to 10, how is their pain medicine? How is their pain, and was it relieved? All right. Disrupted skin integrity, they're going to have that, aren't they? Because the surgery. And remember, clean sutured incisions heal by first intention or primary intention. An infected wound is left open to heal from the bottom up. And that's called, the method is healing by secondary intention. The physician always performs the first dressing change and inspects the wound and orders wound care. Inadequate oxygenation. So I want you to turn to page 290 now and look at the different types of sutures on that picture. That is on figure 17.9. So there's steri strips, there's sutures, there's interrupted sutures, and there's continuous sutures. There's staples, there's retention bridges, and retention sutures. Those retention sutures, oh wow. So you've got sutures underneath, and then this is, a lot of times you'll see this in an obese patient because they need a secondary type of suture to hold the skin together. And that's the retention suture. Now remember here too, we talk about dehiscence and evisceration. So dehiscence, what's the difference? Dehiscence is where the wound opens. Evisceration is where the guts come out, or the intestines come out, or an organ comes out, right? So we know the different types of sutures. We know evisceration and dehiscence. Now there's another thing I want you guys to know. When you look at a dressing, how does it look? So on the bottom of page 290, in that first column there, it talks about, in the immediate post-op phase, wound drainage is often bright red, which is called sanguinous. So sanguinous dressing drainage is red. As the amount of blood in the drainage decreases, the fluid becomes pinkish, and that's serosanguinous. It should progressively become lighter in color and thinner till it's straw-colored, and that's called serous. So those are the 3 colors of drainage that you're going to see on a dressing change. Okay. So that acute pain, pain receptors are stimulated because tissues are cut and stretched during surgery. Most severe during the first 48 hours after surgery. Administer IV opioid analgesics until they can take oral. Patient-controlled analgesia, that's that PCA pump where they can control how much analgesia they get. But remember, that's a set dose. So as many times as they press the button, they can only get so much medication. Ask the patient to rate the pain on a scale of 1 to 10 and verify that last dose of pain medication given. And that's important not only to follow so you don't give them too much, right? But it's also to tell, is the medication holding them? So if they were given a pain pill and it didn't decrease the pain, maybe they need something stronger, and that's where you would need to call the doctor and explain that you gave them a Vicodin, their pain was an 8, and after an hour it was only a 7 still. So maybe the doctor's going to say, well, okay, well, maybe we'll give this patient 2 Vicodin. Because remember, some patients feel pain more than others. Also, so better if the pain is treated before it becomes severe. So don't let that pain get so severe and out of control. So keep them medicated, and that's getting that blood level, that therapeutic blood level of pain medication. So you keep it under control so you don't have that hill and valley of pain. No pain, a lot of pain. No pain, a lot of pain. No, we want to just constant no pain so that they can turn and cough and deep breathe and position change. Turn and cough and deep breathe. Back rubs can be soothing. Relaxation exercises and mental imagery often are effective, or combined with other measures can help their acute pain. That impaired tissue integrity, so incisions are closed with sutures, staples, or tape, and we saw those pictures on the top of 290. First, primary intention, clean sutured incisions. Secondary intention is the infected wound is left open to heal from the bottom up. Tertiary intention is the wound initially left open and then later closed. Disrupted tissue integrity, so they might have a drain. Now there's different types of drains. There's a stab wound drain. If you turn to page 292 now, you can start seeing some of these drains. So the Penrose drain is just like a flat open tube. It's just left to drain drainage out of a wound. A hemovac and a Jackson Pratt, they create negative pressure when they're compressed. So the hemovac is D, and up in the corner on C, you can see that bulb syringe or that bulb suction, and that is your Jackson Pratt. So that is squeezed and tight, and then the top is put on. There's a little lid on the top. And then as it fills, so it creates a suction, and it fills up with fluid because it sucks the fluid from the wound. And when it's full, it will be open. And then you'll empty it out and count that drainage. And then you'll squeeze it again and put the lid back on. And then it does the negative pressure where it sucks the drainage out. Now the hemovac is D, and what that is, it's like in between those two flat discs is like springs. So you squeeze that so it's flat, and then as it pulls the drainage out, it will lift up and open up, and that too creates a negative pressure, meaning that it pulls out any fluids that need to be taken out of the wound. And then we talked about the wound drainage that can be sanguineous, which is bright red, serosanguineous, it's pinkish, and then serous is lighter in color. Dehiscence and evisceration, we talked about that. It must be important because this is like the third time, that I talked about it. So avoid strain on the suture line. Teach patients to support their incision when coughing, so you can use a pillow, a folded blanket, and when they get out of bed they can hold on to that so that their wound doesn't feel like it's pulling. If dehiscence or evisceration occurs, Cover the wound with sterile dressing saturated with normal saline and notify the physician. So now we've talked about that several times. Signs and symptoms of wound infection don't develop until the 3rd to 5th day after surgery. It includes pain, the classic signs and symptoms of infection. You need to know this. So pain, fever, redness, swelling, and purulent drainage. So that's not normal drainage. That's not sanguinous, serosanguinous, or serous drainage. It's purulent. It shows that there's an infection there. Prevent wound infection by decreased exposure to microorganisms. So we're going to use aseptic technique. Maintain patient's resistance to infection by using clean technique, washing our hands. Patient teaching should include signs and symptoms of infection so they know what to report, right? If they know that something's swollen or hot, they can tell you. Inadequate oxygenation, so we're going to document the respiratory rate every hour for the first 24 hours. And I don't mean count it for 15 seconds and then take it times 4. Count it for a full minute, because it's so important after surgery that they breathe adequately. Signs and symptoms of pneumonia would include dyspnea, trouble breathing, fatigue, fever, cough, purulent or bloody sputum, and wet breath sounds. So when you listen to their lungs, are they clear or do you hear crackles? And then if you do hear crackles, have them cough. Support their dressing and cough, and maybe that will clear up those breath sounds and they'll be clear again. Frequent position changes and coughing and deep breathing are very important. Incentive spirometer to promote lung expansion. So I want to point you to figure 17.3 here to the different types of incentive spirometers. So you've probably seen the one on the bottom there with the it's like a little, what is that? Accordion that goes up when the patient sucks, and they'll suck it in and they'll raise that yellow device up to see where the little yellow measuring thing is on the spirometer. So they should raise it up that high. And if you keep raising up that little lever, then they have a goal to expand their lungs, so they know how high to raise it up to. And then the other one is just a different type of incentive spirometer. But we want to be sure to, we've instructed them before surgery on how to use an incentive spirometer, and now it's going to be important that they do it after surgery. So urinary retention can be a problem. I know we talked a little bit about that. So we would need to monitor their output. In the first 24 hours, urinary output's reduced because of stress. Monitor urinary function by I&O. Check for bladder distension, measure their abdomen above their bladder. If patient does not void within 6 to 8 hours, you might have to catheterize them, but you want to try to see if they can do it on their own first. Sensory stimuli help voiding difficulty. So sometimes water running can encourage a patient to go to the bathroom, can urinate when they hear water running. For some reason, it's just a stimulus that encourages them to urinate. But sometimes just being stressed out and being in the hospital and being in an unfamiliar position, it's hard for them to void. So try to get them in a position of normal urinating, if you can. Constipation is a big problem. So inspect and palpate for abdominal distension, auscultate bowel sounds, flatus, or the gas, means digestive tract is functioning again, so peristalsis is beginning. And we're going to verify that with bowel sounds. Measures to promote flatus may be ordered. Getting out of bed is the best thing to promote flatus. Get those bowels moving again, the digestive tract moving. Early frequent ambulation prevents GI discomfort. Intake of normal fluids, normal diet, all stimulate the peristalsis to get going. If GI function does not resume, the patient has a paralytic ileus. That means it's kind of paralyzed. It's manifested by abdominal pain, distension, tenderness, and absence of bowel sounds. Sometimes it's just time to take it until it starts again. Moving the patient around, if you can get them up to get things moving, that really helps. And frequent early ambulation. Patients should have a bowel movement within a few days after resuming the intake of solid foods. Well, that's fine, except what if they've had pain medicine? Well, we know that opioids, pain medicine, can constipate the patient. So you got to keep that in mind. They might need something. If they haven't had a bowel movement in 3 days, they might need a little help. But remember, they haven't eaten either. So it takes about 3 days for food to go from your mouth to your anus. So that's why they kind of use that 3-day rule. So remember that, I just want to reiterate this because it's important. Early frequent ambulation prevents GI discomfort. Intake of oral fluids and ingestion of a normal diet all help to stimulate peristalsis. And that is on page 295 in the middle of the page under constipation. All right, I know this is a long lecture, sorry. Fluid volume deficit. So usually start with clear liquids first and then advance to full liquids if tolerated. And then if the liquids are retained and tolerated, we'll advance to soft and then regular foods. When liquids are tolerated, IV is usually discontinued after that. But you don't want to discontinue the IV until you're sure they start fluids, because otherwise you might have to start another IV. To promote healing, the diet must provide adequate carbs, protein, zinc, iron, folate, vitamin C, B6, and B12. Discharge teaching. So the doctor may have ordered certain medications, maybe medications related to the surgery, maybe antibiotics, pain medication. They need to know about how to take care of their wound, if it needs to be cleaned, can they take a shower. Those are all things we're going to teach them, and those would be orders from the doctor. Do they need home health? They need somebody to come to their house and clean their wound. Or what if they got a colostomy and they need ostomy training? What if they need home antibiotics? They have to go home on antibiotics. You need a home health nurse to come teach them how to give themselves IV medication. Then they need to know what's their diet at home and about their fluid intake. So this is just a post-op complication. Guess what this is? A map, a concept map. So post-op complications, this is just on complications. Now, if you did one just on a certain type of surgery, that's fine. If you choose to do one on surgery in general, that's fine. But see how this one is. So they used pictures. There's respiratory complications and pneumonia, paralytic ileus from the colon, the gastric, nausea and vomiting, evisceration, dehiscence from the wound, infection, And then circulatory, and circulatory has two branches, hypovolemia and pulmonary embolism. So see how it kind of, this is someone's representation of a post-op complication, then a urinary complication. So concept maps are great to tell us about potential problems or how things work. All right, thanks a lot.